So I'm Don Delgado. I work with Tekscan, and I just want to welcome Dr. Curtis Westersund to a fun and exciting webinar today. Thank you all of us for joining, and hopefully this is something that will help you in your day-to-day dentistry. Dr. Curtis has been practicing for longer than I can remember, but he's had some very good results with some patients, and hopefully this will help all of us. Go ahead, Curtis.
I think Don's memory's just a little bit shorter than it used to be. I've been practicing about 40. It's coming up on my 42nd year, and so what we're going to talk about, and if everybody could mute your computer and maybe just because of internet speed, just turn off your video camera, that'd be great. And what we're going to be, is someone still talking?
Hang on, let me get that, take care of that. Hang on, Curtis. All right, you should be good to go.
Okay, so what we're going to be talking about today is TMD pain solutions, and this is something that affects not only the general dentist, but a variety of different specialists. Now, when it comes to talking with, let's get my computer working. What are frustrating problems in the dental office? We all have these frustrating problems in the dental office. We have our team, our staff. We have frustrations with, they all want to get paid more. They all want to work certain hours. Are they there? Whatever it becomes, our team becomes a frustrating problem. Dental insurance in North America, I'm not sure what it's like in Korea. I'm sure it's the same in Australia. Obviously, in North America, we have dental insurance, and some practices even have to hire extra bodies just to process dental insurance. Post-COVID-19 bills. Now, I'm glad to see that the Korean dentists on this are back at work. Way to go, guys. That's really good. Unfortunately, most of us are still somewhat isolated, and so we're not able to do that. But the one thing that we're all able to deal with is figuring out jaw pain. Figuring out jaw pain, I mean, let's face it, that's what we do all day, right? We've got that. We've got that. If we see something like gum recession, we know what we got to do. Maybe we believe it's toothbrush abrasion or something like that. Maybe not on the picture on the right side where he doesn't have any toothbrush abrasion. But we know that we're going to do some crowns, we're going to do some fillings on those, and we're going to help and try and improve that person. We understand that. Maybe somebody comes in, they have sensitive teeth. They come in to see maybe the hygienist, and they're going like, oh, please don't touch that molar at the back. It's really sensitive to cold. All the rest of my teeth are great. Well, we kind of know that maybe we're going to put a crown on that tooth, or we're going to do a root canal, right? We're going to do those types of things with sensitive teeth. How about when this happens? When a veneer breaks or a crown breaks. One of the things I always notice is that patients always say to me, oh, your veneer or your crown in my mouth broke. It's always your veneer and your crown. It must be something that you've done. Can't be something that I did. And so we look at these and we go, okay, we're just going to have to replace that. You're not quite sure, but that's pretty common. And what's our answer for a lot of these problems is called a pop, or what I would call a piece of plastic solution. And we're all familiar with these. You make a piece of plastic, goes on the upper arch, and that's going to solve the problem. We might even joke about it. We might say our patient has a distinct lack of acrylic. And so we go and make them this piece of acrylic that they're going to wear at night. And a pop should fix everything right up. And unfortunately, quite often it doesn't. So that leaves us in a little bit of a quandary, a little bit of confusion. We're trying to figure out what it is we should do. Now, for a lot of us, I know for myself, for the first 20 years of my practice, I was really frustrated with treating what I knew to be TMD. You know, I was kind of overwhelmed by all the anatomy, looking at all the anatomy that's involved, and everybody seemed to know more than me. And so that was kind of a confusing aspect. And there's a variety of treatments. You know, what works and what doesn't. We just talked about having Steve Almost do some education. Steve Almost is a very knowledgeable guy, and he's got a lot of things going, but he might treat slightly differently than, say, what I do. And so what do all these various treatments learn? If you're in Korea, I'm not sure what options you have, but I'm sure there's many options where you can go. And the same would be in Australia. You can go to a fancy school. If you're in North America, you could go to Pankey or Coyce or LVI, and you go to these fancy schools to learn more. But which one should you go to? Who do you trust? How expensive is it going to be? Right? You have to leave the office. How much time are you going to leave the office? And if you really think about it, does treating TMD really work? There's a lot of people out there that say, look, it's only jaw surgery. That's the only way you can treat TMD. And I have a good friend of mine that's an oral surgeon, and he gets sent patients by other dentists, and the patients go, they got TMD, can you do jaw surgery? Or maybe you think that it's only orthodontics. And what I'm going to try and do is show you that it's actually more than that. First, my name is Curtis Westersund. I'm from Calgary, Alberta, Canada. This is a picture of Lake Louise. It's up in the Rocky Mountains, about an hour's drive from my house. This is probably what it looked like about a week ago. So it's still very, just starting to warm up in Alberta. I've been in practice 41 years. I focus on TMD and sleep and chronic pain. A privilege to be an author in Cranio, the journal Craniomandibular and Sleep. I got written in, I have a chapter in Robert Kirstein's book. And many of you know who Robert Kirstein is. He was on the webinar that we did this morning. The Handbook of Research on Clinical Applications of Computerized Occlusal Analysis in Dental Medicine. It's a great book. If you look up Robert Kirstein's book, you can find this. The newest edition has 3 volumes, a lot of research in there. I get a chance to lecture and train around the world. I'm a vice president, and I hold a mastership at ICMO, which is the International College of Craniomandibular Orthopedics, which we just talked about as being a group of like-minded dentists who are looking at using measurement and biomechanical measurements to figure out what's happening in the bite. So, jaw pain. I understand you guys understand jaw pain. You take a look at this, we see a swelling between 3.4 and 3.5. You guys have got this, right? You guys, it's endo, or it's perio, or it's a cracked tooth, right? And you look at that and you go like, oh, I know what happened. This person, and actually, let's take a cone beam CAT scan. And let's look at, this is the cone beam CAT scan of that person. And you figure, look at, there's probably a endo access and the tooth cracked, or there's probably a big old filling that has eventually killed the tooth. Something's going on. It's kind of an isolated periodontal issue, but you know that you've got it. And you know that when you're going to look in the mouth, what are you going to see? You see a big filling, or you're going to see an access opening. But when you do look in the mouth, there's nothing. There's a little tiny pit and fissure filling on the 3.5. There's nothing on the 3.4 except for a blue mark. But then again, those of you that know how to use T-scan, you would see, after you take a T-scan, you would see something that's happening in this 3.4, 3.5 area. And a problem here is showing up. Now, my lecture is not about making you a better T-scan user. I'm going to show you some really new ways to use Tekscan, but I want to introduce this Tekscan to a lot of people who've not seen it, who know nothing about it. And all these little red towers are all areas of high pressure that's happening in that person's mouth. And that's what those little red towers are telling us. And so we end up losing that tooth. We end up having a problem. How many of you have had this happen? Okay, how many have had this happen? Think about this. You do a crown. Let's say you did a zirconia crown. And, you know, those things are tough. You know, it takes a lot of burrs to cut one of those things off. And the patient says, oh, I'm still numb here on the bottom, but I think the crown feels high. And then 2 weeks later, they come back and the tooth, they say, no, the tooth was high, but now it's fine. Well, what happened? Did the patient grind this tooth down? You can't even take it off with a diamond burr. So what happened with that patient? Should you be happy that the patient no longer feels a problem? Maybe the patient did something with posturing their head and neck to get rid of that high spot. Have you ever had a patient have this happen? You lost my bite. I get a lot of these all the time where they go and say, this dentist did all this work, or this dentist did one crown, or this dentist did one tiny little filling, and now my bite doesn't feel right, and I don't seem to have a home. And what do you do at that point in time? How do you solve that problem? Well, what about this? What about the patient that comes in and says, my jaw clicks, can you make it stop? And you take a cone beam CAT scan and you see that that right TMJ is severely damaged and the condyle severely damaged. The ligament space has probably been altered to some degree. So what do you do to stop it? Well, what's our traditional approach to occlusion issues? Our traditional approach to occlusion issues is to deprogram the bite. In other words, we're going to put in a pop, or we're going to put in maybe an NTI, or I'm not sure if any of you in Korea or elsewhere have heard of a Quais appliance where they have this anterior disclusion. But the whole purpose of doing deprogramming of the bite is to allow them to stay in a habitual arc of closure, but just to alleviate some of the muscles, alleviate some of the inflammation in the jaw joint part of the time. Now that's the traditional way, and my son who's on this webinar, that's what he's in dental school, he's gonna learn that you want to deprogram this bite so that it can start to feel better. And you may make some casts, right? We all make casts. You do a diagnostic wax up. And what are you looking to do? Well, you're looking for aesthetic concerns. And then you're going to look at the tooth and gingival mechanics. And you're going to say, well, that implant should go here. We need to do crown lengthening on this tooth. And we're going to keep everything just the same otherwise. And at the very end, you're going to look at the function or occlusion. That's going to be almost an afterthought as you go through it. What I suggest we do is we should alter this. We should look at reprogramming the bite. In other words, how can this bite be made more relaxed, to be made more biomechanically ideal? We have to address something called postural strain, which I'll get into. We have to look at the microocclusion, and everybody that has a Tekscan understands about microocclusion. And then we have to find a biomechanical closure pattern for these patients. Might be the same as their regular closure pattern. Quite often it's different. And so we're using this to reprogram the way people bite together. Now, those protocols, we're going to do a whole body assessment. We're going to look at, I got to let you in on a little tiny secret. 41 years as a dentist. Not once has a patient come in with just a head. Patients always come in with a neck attached to the head and a body, and usually some limbs involved in there as well. I never get a box sent to me in the mail and I open it up. Oh, Mrs. Jones, how you doing? I'm doing okay. You know, we don't get that. We always have a head connected to the rest of the body. Basically, what I always like to say is teeth to toes, because we know that what we do in the head, in the mouth, in the occlusion, will go all the way down to the feet and affect the feet. Then we're going to look at the functional occlusion, how that patient's able to function, how they're able to breathe, not just during the day or not just at night, but how they're going to breathe during the day, how they're able to function properly, how that TMJ joint is going to work for them. And then finally, we're going to look at the aesthetics and the support, because once we've solved the first two, we have the ability to make aesthetics that last longer. And we have the ability to make aesthetics that doesn't break down or cause more problems. So what changes? Well, we can diagnose more. We can obviously treat more, and we can heal more. And I tell you that right now in North America, what our biggest push is going to be is, what services do I have on the shelf that I can take off the shelf and provide for my patient that allows me to diagnose, treat, and heal? Because those are the things that we normally do, but now I can do more. Now, I know you're all great dentists. You're all fantastic dentists. But why do patients come to see you? Why do patients see you? If you're in Toronto, why are patients coming to you? Because they trust you, right? They trust you. That's the only reason for that patient to come. The patient isn't coming just to find decay and gingival issues. Those are part of the problems. I don't care about that. We can all do that. What they want to know about is, what's in my future? What is there that I should worry about? And if we don't provide a full diagnosis, if we don't inform our patients, then we run into the problem of giving them surprises in their future, giving them things that are breaking down and failing or causing pain. Now, this is just as important for a general dentist as all the specialists. If there's any endodontists out there, how do you know that tooth needs a root canal? How do you know it's not the bite? How do you know that the periodontics is caused by them not brushing and flossing and having too many sticky starches and not due to occlusion? How do you know, if you're a prosthodontist, we're all basically prosthodontists, we're all rebuilding teeth. How do we know how to rebuild that tooth, or where we should rebuild that tooth to? Or does rebuilding a tooth on one side have the potential to create an issue on the other side that we didn't touch? Orthodontics. If we're going to move teeth, where are we going to move them to? Sometimes aesthetics isn't just enough. It's not just enough to make somebody look pretty. We have to make them functional. And of course, if we're going to do oral surgery, if we're going to do jaw advancements, if we're going to do a lot of very in-depth treatment, what are the things that we need to consider? And in our traditional approach, we didn't see that. Now, this also applies to TMD. So TMD, what is it? Well, it's not a diagnosis. I'm sure all of you know this. I know this, that you guys understand. TMD is not a diagnosis. It's a basket of problems. You can't say, oh, this patient has TMD. You can say this patient has myalgia. You can say this patient has migraines. You can say this patient has a non-reducing joint, but you can't say they just have TMD, because that's not a diagnosis. It crosses all professions. I mean, chiropractors, medical doctors, everybody jumps in to help treat TMD. Cranial sacral therapists, they all jump in to help TMD. But there's over 150 signs and symptoms that I have listed down that have to deal with TMD. 150 signs and symptoms. That's very complicated. But fortunately, the treatment, though, can be fairly simple. And for the vast majority of cases, simple treatment makes great correction. Now, all of these occlusions have their own unique physiologic problem. We can take a look at all these. They all have physiologic problems. Some you can see, some you understand, some you may not understand that it's creating a problem. But every single one of these is a TMD patient that's come into my office, someone that I've been trying to help. And some of them are very frustrating problems. When you go and talk about occlusion, there's a lot of misconceptions and there's a lot of viewpoints. I'm not here to argue viewpoints. I'm here to tell you what I do. I totally respect every dentist and all their ways that they like to go about it. There's many different ways to solve these problems, but I want to tell you how I do it. And of course, there's many different treatment options. And unfortunately, there's a lot of failures. And that's why a lot of dentists are going, I don't want to touch this stuff. But if we have a methodical way of looking at this, it can be much better. Well, what starts TMD? I say that a lot of TMD starts at this age, where we have a little baby, and that baby is laying on their back, breathing through their mouth. Why? Why are they breathing through their mouth? Well, because their nose had too much of an impedance for their air coming in. So they had to open up their emergency air hole for air to come in through their mouth. And that's going to cause a whole bunch of problems. I'm going to show you a video from Dr. Konstantin Ronkin. You can see this video on YouTube. If you look for airway and TMJ, it's under Dr. Konstantin Ronkin, R-O-K-I-N. And his video is basically this. The normal way to breathe is through your nose. But if you have lymphoid tissues like adenoid tissue, if you have a deviated septum, if you have allergies, what are you going to do if you can't breathe through your nose? You're going to open up your emergency air hole. You're going to drop your tongue down, you're going to open up your mouth, and you're going to breathe through your mouth. We do that automatically. But what happens when that tongue drops down? The tongue has to go somewhere. And when the tongue drops down, it's no longer creating forces on the roof of the mouth to balance out the forces from your tongue and your cheek, or from your cheek and your lips, I should say. So your cheek and lips push inwards and your tongue's not pushing outwards. Well, what can happen? Well, we can get a narrowing of the upper arch, or we can get a shortening of the upper arch, or we can get both. And so what happens now that the tongue is low, we develop a tongue habit that doesn't help us. Maybe our tongue acts like this pink orthotic that goes in between the teeth and keeps the posterior teeth from erupting while allowing the anterior teeth to erupt and creating something that I would call a bicuspid drop-off. Now, some people call this a steep curve of Spee, but it's more, to me, it's more a habit of what the tongue's been doing to create this problem. Now, when you bite together, the teeth don't mesh like they did, right? The teeth don't mesh the same. So in some patients, we get a dislocation of that TMJ. And that causes muscle strain, and that causes clicks as that pops back into reduction in place and dislocation out of place. And eventually that may cause clicking, pain in the muscles, even headaches, neck aches, and other types of problems. But it doesn't end there, everybody, because some patients will combat this by grinding their teeth. And as they grind their teeth back and forward, they begin to wear out their teeth. And it's all to try and allow that mandible to come forward. But unfortunately, they wear out the teeth, or they may wear out the ligaments of the jaw joint, and they have a non-reducing jaw joint, and they have a limited opening. Now, that can all happen. It happens in some, happens in many, but here's what happens in most, is when that tongue is sitting back there, it's now restricting the airway. How do we combat that? How do we make the airway bigger again? By tipping the head up and bringing the head forward. So we got a forward head posture. Now our balance, our postural strain is into our neck and causing problems in our neck. So again, that's Airway and TMJ by Dr. Konstantin Ronkin. Go look it up on YouTube. Give him a thumbs up. He is a great dentist. So now I've identified 3 problems of TMD that I see in my patients that I need to fix. It's a picture of me in my office back in the days when I could work. So one of the problems is the bite's imbalanced. We have a micro-occlusion problem. And those of you that have Tekscan, if you Tekscan, used it in the past and have some training, you understand that. But another problem we have is the bite is misplaced. And quite often this is jaw development. So we may have a distally positioned mandible, or we have some type of torque, and it's all due to jaw development. Airways tied into that as well. Airway not just at night, but airway during the day. What's the third part? And the third part is the bite's being influenced. In other words, there's postural strain. The body, there's an ascending force into our bite that creates problems that I can say for sure affects how people heal. This bite being influenced is something that we typically don't look at, and that creates a whole bunch of problems. Now, let's look at each one of these individually. Problem number 1, malocclusion. We understand that a lot of people have a malocclusion, right? And how's that? As regards to the balance, timing, and force affects your body. And if you are not familiar with a Tekscan, if this is all new to you, I'll try and explain some of this. But for those of you who are experts on Tekscan, you know all this stuff. What do we see here? We see a red bar on the top picture, no red bar in the bottom picture. What happened? Well, there was an occlusal adjustment. And for those of us with Tekscans, this is nothing, this is easy. But did we look at that patient before and after? Now look what happened to that patient in the course of about 20 minutes. In the course of about 20 minutes, we've changed her, the rounding of her thoracic vertebrae, the curvature of her lumbar vertebrae, the tipping of her hips. We brought her shoulders back, her head more upright, and her head more level in a proper ideal posture with her cervical vertebrae. That's all from changing the bite that little bit. Whoever's talking, if you could mute yourself, that'd be fantastic. Appreciate it. Okay, so we have some new hurdles. We understand occlusion, but we have to deal with micro-occlusion. We understand occlusions in millimeters, but we have to deal with occlusion that's in microns or thousandths of a millimeter. And just using paper is not enough. And I'm sure there's many dentists out there that think that articulating paper, they're a guru. They're the Jedi Knight of articulating paper. And I appreciate your confidence, but studies have shown that it's not true. You can't measure a malocclusion with just paper. You need to have some biometric measurement. And for that, we use the Tekscan. And again, Tekscan, very simple to use, has 1,100 sensors. It measures down to 4 microns of pressure on the Tekscan it can measure. The wafer is about 90 microns thick, but it folds into the patient's bite when they bite into it. And also it gives you real-time data. Now, please understand, we could say that I have a conflict of interest with Tekscan because Tekscan is something I use all the time. I have 4 Tekscan handles in my practice. I use a Tekscan every day when I'm working. There are other units out there, and we had a discussion this morning about OcluSense, its pros and cons, but there are other measurement units out there. I don't have anything other than Tekscan. This is what I use. This is my way that I treat. And I don't see that as a conflict of interest because I'm not getting any kickback from Tekscan for me using this. I'm just trying to share and teach people how to use this. Now, I want you to understand that balancing forces can be seen with this Tekscan. It's functional. You can have patients grind from side to side. You can see their functional contacts. And understand that balancing and working contacts on the bite have a greater flexure than a greater strength of flexing that tooth than vertical loading. So all the marks outside the red dots or blue dots are marks that we really don't want to have. And so what we're trying to do is we're trying to make bites more balanced and more functional. The way I explain it to patients is this.
So the tooth is much like a Q-tip. We can put a lot of force that way and it doesn't break, but a little bit of force that way and it fractures right where the tooth enters into the bone.
So gum recession, abfractions, sensitive teeth, we all know that those are occlusal interference issues. And we can adjust those if we pay attention to microocclusion. So what are the type of prematurities? Well, you have a class 1 interference on the lower buccal on the outside, upper buccal on the inside. Right in that area, as those teeth move into a working side contact, that's a problem. We have class 2 interferences, lower lingual cusp, upper lingual cusp on the outside. As it moves down, what are we going to have? A class 2 interference. And of course, what we know what class 3 is, that's when we have a bouncing contact, and that moves, when the lower moves to the opposite side, it's in contact, and that's a balancing prematurity. And we know that that can be a problem as well. So just to get an understanding of what we're talking about, those are the areas that we may see, and then we're going to do reductions. Sorry, jumped ahead. We're going to do reductions on these teeth, on the top and bottom teeth, to make these interferences go away. We're going to make sure the bite's balanced, but we're going to remove interferences. The Tekscan helps tell us those are there. Sometimes we get interferences, we don't see them. The Tekscan says, oh, there's a problem around 3-6, but I don't see it in the mouth. And I had this experience in Moscow once with Konstantin Ronkin. He was treating a patient, and we could see from the Tekscan there was a balancing side contact on 3-7 on the lower buccal cusp lingual side, and we couldn't see it with the paper. We could see it with the Tekscan, and we couldn't see it with the paper. We had to use occlusal wax to be able to pick up that contact, because we can't always see what's happening with paper. Paper's great, but it is not accurate for us to do coronoplasties and to grind down teeth. Now I'm going to show you a patient of mine and how John came in. He actually is an iTero rep, and he came in to fix my iTero, and he had broken a tooth, and we'll just see what we did with John.
Hi, John. How are you today?
Great, thank you.
So tell me, John, what's happened with your bite?
Basically, I feel that something's a little off. I broke a tooth in the posterior, and it was an implant that I had many years ago. So I'm just a little concerned about my bite.
Does your bite feel balanced?
It feels balanced.
Okay. And have you had any other wear or recession?
I've got some lower anterior recession going on in the front, and nothing else that I've noticed.
Okay. And you can open wide and close?
Yep.
Good job. Okay. So what we're going to do is we're going to check your bite. Okay.
Perfect.
So in North America, this is a fairly standard patient. He's got a broken tooth on the upper right. He's got some recession on some crowns in the front on the lowers. So what we're going to do is we're going to check him. And first, I'm going to show you how to use a Tekscan. Here's Tekscan handle. We're going to place a bite fork into the Tekscan handle. And then we're going to place a Tekscan wafer. It has a proper way that we're going to set it up. We're going to slide it in there. Come on, get in there. Wiggle, wiggle. There, all the way done. And we're going to lock it in place. We've got 2 green lights. We're ready to go. So here we are taking the bite.
Bite hard, open. Bite hard, slide the other way, open.
So we had them bite and slide. I mean, we can just have him bite. I also did those, but I also wanted to look at his functional contacts. And this is his Tekscan. And what do we see, campers? What do we see? Dentists love these things. We see a bunch of pink bars. Maybe I could turn that sensitivity down a little bit. But we see that when he moves to the right, there is working side contacts. And when we move him over, just adjust that a little bit, we move more to the left, we also see working side contacts. Okay? So what we're trying to do is we're trying to provide a nice, smooth, even bite. And that's me doing some work. I know that's a horrible sound.
Okay, so we've adjusted your bite.
Yeah.
And it was normal, it was perfect before.
So
You thought so, but how's it feel now?
actually, it feels incredible. I've got more contact points more evenly. It just seems that my occlusion's better.
So just the first treatment, we're going to have to do some more treatments, but we're dealing with the micro-occlusion and the functional occlusion of John, a very easy thing to do in just a few minutes. So before micro adjustment, after micro adjustment, that's kind of the goals we're trying to do. And we're doing this to a very accurate amount that you can't get with just articulating paper. I don't care how good you are. But why does this work? Okay, you guys, I'm assuming everybody here is an expert. Why did this actually work? Why did the Tekscan work? Well, let's say you got a thorn stuck in your foot, okay? What are you gonna do with that thorn? You're gonna walk around that thorn. You're gonna twist your foot. You're gonna change your gait. You're gonna hop on one foot and barely touch the other because that thorn is in your foot. It's gonna make a big difference how you ambulate. Well, if your bite is off more than 20 microns, there's an automatic response to accommodate that bite, that noxious contact. So as you bite together, as your teeth come up, if there is a high spot, we're able to sense that in the pressure sensors in the periodontal ligament of the tooth. And those pressure sensors send a signal off to the brain stem where we have our trigeminal nucleus, and it goes directly there. Those pressure sensors have their cell bodies in the sensory trigeminal nucleus. And it sends a direct signal up to the mesencephalic trigeminal nucleus, or the midbrain nucleus. And from there, it sends a signal to, or instructions to the trigeminal motor nucleus, and that's off to the muscles of mastication. Now, this is really fast. This is much faster than, this is the only sensory nerve that has its cell body in the brainstem, the only one. And this is a hardwired connection. This isn't just a gap with chemicals. This is an electrical connection. And why is it? It's just make sure you don't break teeth. Because if we broke tooth as a prehistoric man, we get dental infection, we could have a problem. So we've been genetically chosen to have this proprioceptive ability. And how sensitive is this? Well, I said 20 microns. What's 20 microns, everybody? I have a needle, about 1,230 microns. Human hair, 70 to 300 microns. Talcum powder dust on a little baby's bum, about 50 microns. And dust motes in a sunbeam as you're sitting at home waiting for the COVID virus to disappear. That's about 30 microns. So we're sensitive to even more than that. The T-scan begins measuring at 4. So those little black dots, it's a little fact, those are the early start of measurement of compression on the T-scan sensor paper at 4 microns. Let's go to problem number 2. Problem number 2 is the bite's misplaced due to jaw growth. Okay, here we have a very lovely young lady. She looks perfectly normal, doesn't she? But we know that that isn't always the case. The more you know somebody, the less normal they become. So let's look at what her problems was. She had constant jaw pain. She had neck pain, tension and migraine headaches. She actually had cognitive impairment where she was losing focus at work. She was working as an architect's draft person, and she was having trouble following instructions, reading, drawing, everything she was doing. She had to stand at work, and she had too much sway and instability in her stance. And that was generating body pain. She's unable to work. She's unable to socialize. She's unable to function. She was in a lot of problems. So we took some photos. And again, lovely young lady. These look like pretty normal photos. And what can I say to everybody? Everybody should be taking photos of their patients. Please document what you see. And this is kind of a standard set of photos we take. And she looks perfectly normal, doesn't she? Well, we do have one low shoulder. Her body is leaning forward over top of her hips, and her head's tipped back. We have a lot of lumbar hyperlordosis. She has limited mobility to rotate her head to the left, and she has limited mobility to tip her head to the right. And also, when I tell her to look at her feet, she's fascinated by her right foot, it seems. She's looking to the right, and she's looking up to the left when she looks up to the ceiling. And lastly, we notice that in both photos, her left foot is more forward. So there's a hip rotation along with the hip tipping. Now let's take a look at her mouth. What do you see, guys? Pretty normal mouth, right? Well, we got a 50% overbite. So it's a bit more of an overbite than we like to see. I call this an anterior keyway bite. She has brought her mandible forward so many times that she's got wear on her lower front teeth and her upper front teeth that match and almost form a keyway. It's so perfect the way she continually brings her mandible forward. She's got some minor rotations, not too bad on one side, minor rotations on the other side. For those of you who do sleep, this is a class 4 malapathy, a very constricted oral pharynx with tonsils and the like. Minor rotations on the upper, and we got minor rotations and tori on the bottom. So that becomes a problem. So what are we going to do? Well, we're going to use some equipment. Now, some of you guys use bioresearch, some of you guys use myotronics, some of you guys don't use any of this. But what we see here, this is the equipment that I use. Again, thanks to Konstantin Ronkin for his videos. And what we're doing is we're finding a more biomechanically ideal bite. And we're using a sensor to actually find the bite. And then we're making her an orthotic, and we're adjusting that orthotic. What does the orthotic look like in her mouth, you ask? Well, here's the orthotic that I made for my patient. So on the upper, she's without. On the lower, she is with. And you can see that we've added vertical to her bite. So we brought her mandible down and forward. And using my equipment, my EMGs and my T-scans and my ultra low frequency TENS, I've been able to balance this orthotic out so that she has no interferences. Now, this is an orthotic that she wears all the time. Can I just stop here for a second? I want to make a pact with everybody. Let's make a pact. Let's not use the word splint, because a splint is something that you put on your arm when you break your arm. That's a splint. Let's not use the word night guard, because a night guard, we're not guarding you at night. I'm not, making sure there's no monsters in your closet or under your bed. We're not guarding you just at night. We're actually trying to reprogram your bite daytime and nighttime. She's able to wear this all the time. It pops in and out, and we'll show one in just a few seconds. But she's able to wear this orthotic to make her bite work better. Patients quite often take them out to eat. I have one in my mouth. I take mine out to eat. Here she is getting married, and she sends me this photo of her with her orthotic in, and she's so much better now. She's able to get married and have fun. Her life has totally changed. So how else would that look like? Let's see what an orthotic looks like. Excuse me. Here we see an orthotic. And what we're doing is we're in the process of balancing this orthotic. And so it's tooth colored. Those little tabs on the patient's head are part of the ultra low frequency, or ULF TENS, ultra low frequency. It's a pulse that comes every 1.5 seconds, a very low frequency pulse, very low energy, just to provide simultaneously on both sides of her head, to simultaneously stimulate the muscles of closure so we can get a more biomechanical closure pattern. This is how we solve this. In this next video, I'm going to show you what we do. Here we're pulsing her jaw into the T-scan, and we're getting a record, and you can see on the bottom there's spikes every 1.5 seconds. And then we're doing the same thing over again with paper in the mouth. We're making sure that we have an upright posture, checking both sides. And what we're doing is we're just using the T-scan and ink marks to show us where interferences are. We shut off the TENS unit, and we look at where some of those interferences, and we'll look back on the screen in a second to see where there are some interferences that I don't like, some smudges, some high spots. Let's look at the screen, everybody. And we can see those smudges, those high spots. And we can go back in, and I'm using a straight cone, and I can adjust those. And with experience, you know what to adjust and how much, which ones to tidy up, which of the marks I want to make better. And then we can go back in and try this again with the bite. And we can basically rinse and repeat, get rid of the marks that you don't want and adjust them. But we use the T-scan to show us. And here, when we're getting close to being done, we're seeing a more balanced bite and where things are more adapted. Now what do we do? I shut off these J5 myomonitor from Myotronics. You can use the BioResearch one if you want. And now I'm going to have her clench and grind to the side. Some of you might realize this is kind of like DTR, disclusion time reduction. And I'm going in onto the T-scan, and I'm looking at how quickly everything balances out, where my interferences are. And then I can adjust from that. Here's another example. This is a different case. Here's somebody we rebuilt. So on the upper shows his occlusion We've got some worn teeth. There's some anterior wear. There's some problems with him wanting to bring his mandible forward over and over again and chipping and breaking down these teeth. So what are we going to do? The first thing on the lower left is I made him a dental orthotic that got him into a physiologic bite position for a period of about 6 months. And then once we started getting him, and he's better, he's stable, we're converting to the uppers and temps right now. We made him a new orthotic. And unfortunately, this is happening just about the time the COVID happened. We've actually finished his upper and lower, but I don't have the finished photos because COVID hit us and I was not able to get him back in. But here's another example showing wear and tear. What do you do with somebody that's worn his teeth down so much? Well, I'm sure you could do some gum surgery, you could expose more root, and you could keep him in his habitual closure pattern, but wouldn't you be exposing him to the same forces that caused the problem in the first place? And here we are, we've totally rebuilt his upper and lower, normal sized teeth. This picture is about 11 years old, and none of the teeth have broken, none of the teeth had to be replaced. Everything has been working fine. So that's problem number 2. Let's talk about problem number 3. Remember I said your bite is being influenced. So your posture is influencing your bite. And when we look at this young girl, we see that the photo on the left is different than the photo on the right. Why is that? Well, she's got a low shoulder. Her neck's going to the left. She's got a low shoulder on the left. Her head's going to the right. Then after adjustments of her head and neck, she's more balanced. So what's neutral posture? Well, your ears over your shoulder, your head and neck are level, your shoulders are level, you have a proper kyphosis and lordosis of the thoracic and the lumbar. There's no hip rotation or twisting, knees are even, and you're not over protonating or supinating the feet. Dry mouth from talking too much, everybody. I apologize for this. So what happens with her posture? There's no part of our body that gets a free ride. Stress is not free. If you have strain or stress in your body, that's not free, everybody. That has a cost. And sometimes that cost is to the body's musculature, ligaments, tendons. And at the same time, we're distorting the arms and the legs, we're also distorting the way we bite. And you can only find this out if you're using something like a T-scan to show you, because it's the only way that you can measure that closely. And what's happening at the neck? Because the neck is probably the closest neighbor for posture issues to where we work. And if we look at the head and neck, I apologize. If we look at the head and neck, we see that there is a compression of the spinal column by just a rotation of the first vertebrae on the second vertebrae on the atlas over top of the axis. And you know, here's a little fun fact, that if you rotate the atlas 3 degrees, you have a 23% loss in the volume for the spinal column. And that affects both ascending and descending signals that we can have in our body. Now, this is a picture of a NUCA chiropractor. This is what I use in Canada. We can use this in Toronto too. And this is how we measure, and the treatment is a minor rotating treatment with very little force onto the neck. And the practitioner is able to feel that shifting of the vertebrae. There's no clicking, there's no snapping things back and forth. It is a very low impact adjustment, and it is very useful. Now, if you do not have a upper cervical chiropractor, you probably have maybe some chiropractors, or you have massage therapists or craniosacral therapists. You have somebody that you can collaborate with, somebody that can help you do this head and neck adjustment, this body adjustment. And understand that what I'm saying is that we should be collaborating with other healthcare providers to provide TMD treatment. We can't do this ourselves. The dentist that says, I can do this all myself, is the dentist to run away from, because you can't. You can't do this all by yourself and do a thorough job. So what have we learned? Well, patients are not separate pieces, right? We learned that patients breathe all the time. I have, in 41 years, I've never had a patient that didn't breathe. All my patients breathe night and day. It's amazing. I'm 100%. I think it's kind of important. Observation is important. And there are 3 problems: the bite's imbalanced, the bite's misplaced, and the bite's being influenced. We can affect those problems. And it can be rewarding and reduce stress in our own office. It can reduce problems that we're looking at having. So what do we have to do? Well, we have to think biomechanical. We have to think how the body reacts to things and how we can make that reaction less. So it's not just mechanical. You have to talk to our patients. We have to look, we have to ask, we have to listen to what they're saying, and we have to inform them about what we're going to do for treatment. As a person that just sees TMD patients, that's very important. And that allows us to diagnose, treatment plan, and perform. That's what we want to do. And we can become the mouth doctor. We should be. We don't want to be just another car mechanic. We want to be mouth doctors. So you can learn to solve occlusion-related pain. You can better help your patients. You can have success. That's a choice. Or you can keep writing pain prescriptions. You can keep getting yourself and everybody else frustrated. That's a choice too. One's a success, one's maybe not as much of a success. Those are your choices, your decisions. I want to show you how I do things. There's many different ways to treat all these issues, as long as you're looking at the whole person and not just the bite. So there's my email address, curtis@cool2drool.com. My website's dentallife.com. There's Don Delgado's email and the Tekscan website, and Don's phone number that you can call him at night or day. He'll always answer it.
Thank you, Curtis. That was night and day. I appreciate it.